So we're here at the IS meeting in Melbourne, Victoria, Australia, with Mitchell Warren, who he and I have come all the way from the United States to talk here. But it is important. We covered just a moment ago some of the other things that are going on. There's so much going on here. It's a three-ring circus. And we always try to cover the things that aren't otherwise being covered and backstories and so forth. But there is biomedical issues that need to be probably covered, and I think you can probably address some of those that are important to cover here at the conference.
Sure. So we're at this, every 2 years at these meetings, there's, every possible issue under the sun, and every conference is a turning point. Every conference takes us in new directions. But I think, we're at a point where 2 years ago in Washington, everyone talked about ending the epidemic, and that was coming out of the HPTN-052 study, this idea that treatment was not only treatment, but could also have a preventive benefit. So here we are 2 years later, and the buzz is, UNAIDS before the conference saying we should end the epidemic by 2030. And that is absolutely the right aspirational goal, but of course the question is, well, how do we get there? And you don't just determine your destination and go on autopilot. You need to be incredibly intentional. And there's a huge amount of work about delivering the things we have, and treatment is the backbone of that, and condoms and behavior change communication, things we've done for 30 years with prevention, and for the last 20 years with treatment. We need to do all of that and more, increasing the scale and the pace. But there is the essential need to do other things too. And so this is an interesting meeting in that we're seeing the scale up of the mainstream interventions, treatment and prevention, but you have the amazing, I think, new success story of voluntary medical male circumcision, a biomedical intervention with a huge behavioral and social and cultural component that was demonstrated to work now 7 years ago in clinical trials, and we're finally seeing public health impact. And similarly, oral pre-exposure prophylaxis, proven now 4 years ago, if we can remember. 4 years ago, the IPREX result came out of oral PrEP in men who have sex with men. The FDA approved it 2 years ago. In the last 2 months, we've had both CDC and WHO guidance really telling us, matter-of-factly, PrEP is the real deal. PrEP has a role in combination prevention, but how do you roll it out? Who wants it? Who's going to use it? And we're beginning to see at this meeting for the first time real data to tell us that although we know PrEP is not for everybody, PrEP is for some people some of the time. It can have an important impact. And so that's kind of this middle level of, if we have to deliver all the mainstream stuff, there's the how do you demonstrate the added benefit of circumcision of oral PrEP? And then this meeting too has the whole long-term development agenda, which is really better therapies, a vaccine, and cure. So you've got all of that at play, and you really have to figure out if we're going to get to 2030, deliver what we've got, demonstrate this added benefit of newer interventions, and never lose sight of the long-term end game strategy of a vaccine and a cure, because that is going to be critical. We may bend the curve of the epidemic, as everyone's talking about, by 2030, but to truly end it, you have to have a vaccine or a cure. And that's what this conference is really fundamentally about.
And of course, this conference adds a lot of social implications,
Absolutely.
such as the decriminalization issues that are, and the laws that are being passed that are really inhibitory to the progress of the epidemic, or the progress, or the lack of progress of the, if you will.
Absolutely.
Of the disease.
The elegance of the science, and it is, you see some of the world's greatest scientists here. The elegance of the science is remarkable. But even if everything happened exactly right scientifically, if we don't deal with that fundamental reality of stigma, discrimination, criminalization, we will never end the epidemic. And that's one of the challenges. So no matter how many pills we deliver for prevention or for treatment, no matter how many circumcisions, no matter how many condoms, if we continue to see laws criminalizing homosexuality, if we continue to see laws that criminalize drug use and sex work, we will never end the epidemic, because no biomedical intervention can overcome those areas.
If people don't have that initiative, take the initiative,
Absolutely.
because they feel inhibited about revealing their status because of laws, they won't be there to take the treatments that all these wonderful things
Absolutely.
that we've had made available.
It's so interesting. So just a week ago, before the conference began, the World Health Organization issued new guidelines for what they call key populations. Men who have sex with men, transgender people, people who inject drugs, people who are incarcerated, and sex workers. 5 key populations. And it's fascinating. One of the recommendations, and it's a great one, is that oral PrEP is recommended now as being integrated into combination programs for men who have sex with men. I think the statement is not strong enough. I actually think it should be integrated into all populations,
Right.
because we have evidence scientifically that PrEP can reduce infection of everybody at risk of HIV. Men who have sex with men, heterosexual men and women, people who inject drugs.
Right.
But be that as it may, the guidelines from a week ago say that at least for men who have sex with men, PrEP is highly recommended. That's great, but in Uganda, it is illegal to be gay.
Right. Yeah.
It is illegal to work with
Yeah.
gay people. And yet we have a recommendation that says PrEP is available. So and I actually think the WHO guidance is exciting and important, but that doesn't overcome an issue that in Uganda it's illegal. In other countries, not just in Africa, in other countries people say we don't have gay people. You know, that's not our problem.
Right.
And if you think that as a policymaker or a politician, if you think that you don't have that problem in your community because you're scared of it, you're stigmatizing it, then PrEP has no role to play because we don't need it. So we have to really be careful about how not only is stigma affecting individuals, but stigma affects our interventions, because right now PrEP could get stigmatized as, oh, that's a gay thing. And PrEP can't be stigmatized like that, because PrEP could have impact and prevent infections across all populations.
Well, I think not in defense of, but in discussion with the World Health Organization, they were stating that this was their way, or one of their ways, to start the dialogue with governments.
Absolutely.
And I think that is that now we should, if that is what they want to do, that should be where we put our energy.
Absolutely. And I couldn't agree more. And I think one of the things, and we're at this really fascinating, everyone loves to talk about tipping points, but we are at this interesting point where if I think about this idea of ending the epidemic by 2030, you need, in my mind, at least three things. You need a target, so we've got that, ending AIDS. You need kind of guidelines and policies that support that. So at least WHO is a good example. We now have guidance in this regard for at least the key populations. But you've got to have the actual resources and the environment in which to do that work. So we have great science that tells us it's possible. We have targets that get people excited. We have policies, these coming from global normative agencies, that tell us this is what could happen or should happen. But if we don't resource that, and if we don't really develop the implementation plan, we will live in a world for decades to come where those documents from 2014 are on a bookshelf collecting dust. If we don't resource them and make it happen on the ground, then it really, why have it to begin with? So I think we're at a really interesting point. Do we have the collective ability, the wisdom and the political will to translate the targets and the guidelines into practice? I'd like to think we do, but I don't know.
Well, that includes charging and encouraging and energizing the local population.
Absolutely.
And advocates and activists to do that work. I mean, it's hard for us to come in and look like we're pushing them into something. You know, they have to be almost self-energized. I think this conference does some of that.
It does, and I think, you know, it's challenging. You know, we're in Melbourne, which is a beautiful city, far away from the epicenter of the epidemic, and that's just the reality. I think
Other
that's
than
exciting.
Indonesia
And it's close, although everything's kind of far from
Yeah,
Australia.
yeah.
What I get excited about is standing here in Melbourne in 2014 with this idea that we have these new targets, these new approaches, 90, 90, 90. Where will we be in 2 years from today?
Yeah.
Many of us, thousands more of us, will be in Durban, South Africa.
Right.
2 years from today, 16 years after we gathered in 2000, which was a watershed moment. When I think about that watershed moment, I actually can't help but think of
It's
Uganda,
hard to remember that.
who reminded us then that, you know, the treatment, you know, back in, you know, if you think about the two biggest conferences in the history, in my mind, in the history of the AIDS movement, from a meeting perspective, 1996 in Vancouver,
Right.
when
We
David
actually
Ho
thought,
and others
yeah,
did that,
yeah.
and 2000, 4 years later in Durban, where we said it can't just be something for Vancouver and the U.S. and Australia. It has to be for Africa and Asia and Latin America and what we didn't call then, but the key populations that are greatest at risk in this epidemic. So I'm very struck, because not only where are we going to be a year from now, well, the smaller IIS pathogenesis meeting is fascinatingly enough in Vancouver next year. And the year after that, we're in Durban. So we had 96, we had 2000. To me, 2015 and 2016 are there's a test for us as a community, for policymakers, for funders, for scientists, for
Coming
advocates. If we screw it up, if we don't take advantage of Vancouver 2 next year and Durban 2 in 2016, we will have missed the opportunity, and I actually think we won't get to 2030 with ending the epidemic. If we don't, and I think that for me has to come out of Melbourne. Where do we want to be next year in Vancouver? Are we on the road to 90-90-90? Are we on the road to, every conference has its own little press release and its new, it was getting to zero. Now we want to get to 90-90-90. That's all, and I don't mean to minimize that. We want to get to zero. We want to get to 90-90-90. But where are we going to be in Vancouver? Where are we going to be in Durban? And if we don't get on track, then 2030 gets 2035 gets 2040. So I think the community has to really rally to articulate very specific interim milestones to know that we're on the right road. And if we're off, if we kind of diverge and went off course a little bit, if we missed Vancouver and end up in central Canada, we got to course correct back to Vancouver. And not to beat the analogy of our little roadmap,
right.
But we need a clear path from Melbourne to Vancouver to Durban to ending the epidemic. And I haven't seen that yet. I've seen people say, here we are in Melbourne, here's where we're going to be over here. But I want to know how we are going to navigate there.
And I think that it's a normal business plan. I mean, any business will operate that way with 1 year and 2 year and 5 year plans. And stuff.
Absolutely. And as we were talking earlier, we're sitting here. It is June. I lose track of time. We're July. July 20th. 20th, yeah. Something like that. We're sitting here mid-July. There are companies all over the world who now this week will release their second quarter results for 2014 because the quarter ended in June. Yeah. So weeks later they'll make decisions. But here we are sitting in Melbourne, where global leaders in the AIDS movement are still using data from 2012 because we don't have the business-like system, the mechanisms to help us understand. Because I want to know, did we do the right things in April, May, and June this year?
And
if we didn't, let's fix it. Let's do it better.
And if there's good operational models, let's deploy them and replicate them.
Absolutely, because one of the things that would be great is, did we do the right things in Kenya in second quarter? And if we did, then how do we translate that and implement that in Rwanda or South Africa?
Wherever else.
And if we did something wrong in a particular community, if we have a bad law in Uganda, what are we going to do for the next quarter? Because if we look back, if we sit next year in Vancouver or in 2 years in Durban, and we look back and talk about data that's 2 years old, we've missed it. Yep. We are out of date, and we're almost by definition going to make bad decisions with outdated data.
You keep banging your head against the same wall, it doesn't improve anything. You got to remove that and employ something new that's going to work. Yeah.
And I think we actually, I've said before, I think we're seeing that with circumcision. Proven years ago, it was a very slow number of years of not being able to translate clinical trial results into public health impact. And yet the global community, led really by the President's Emergency Response for Aid Relief, PEPFAR, and by the Gates Foundation and UNAIDS and WHO, and pushed by advocates in Africa, community groups saying, we want this intervention because we know it can help us. And we've been part of a group it's called the Truth Campaign, the Truth Tellers on VMMC. And it's African advocates collaborating, saying, here's what we need to do and here's how we need to talk about circumcision. And they're saying to the implementers, you have to involve women, you have to involve, and those things were not happening in 2 or 3 years ago. And now you're seeing it, and guess what? The targets were exceeded last year. But we don't report on it because the reporting systems are not.
And it's ground up. Yeah. It's obviously top down initiated, but ground up once the ball gets rolling.
People love to talk about all politics is local. All HIV prevention and all HIV treatment is local.
It is.
You don't reduce viral load. You don't prevent an infection with a global policy. Right. They enable it. They help it, certainly. Of course we want those things. But all prevention, all treatment is local.
Mitchell, thank you so much for being here.
My great pleasure.
I'm hopeful that we can have all of these good things happen.
Absolutely. Well, we should, this is a field for 33 years, where, it's easy to get frustrated, it's easy to get demoralized, it's easy to see things going slowly, poorly, inefficiently. But there's also so many reasons to look now in 2014 and say, we have made so much progress as a global community. We actually don't spend enough time celebrating the successes, and they exist. But if we don't understand how we made them successful, and learn from them. So I think for me, one of the big things, we need to learn our lessons faster and apply them faster in real time. And that's still not there, but I think we're getting better at it.
Clinton said that a number of years ago, and I think it's still so true.
Yeah, learn it faster and do it faster.
And work with the models that are working.
Yeah. And it's one of the things, we talk about coverage, numbers of people on treatment, numbers of people, numbers of infections averted. It's not just the scale or the size, it's the pace. And we've seen amazing uptick with treatment, with circumcision, with other interventions. And the issue is, do we have the resources to make sure the pace, because it's not just how big, but it's how fast. And speed matters in this regard.
Thanks again.
Thank you.
Yeah.